We are thrilled to welcome you to our 2020 Connected Health Summit Consumer Engagement and Innovation virtual conference. For decades, we have been looking closely at consumers' use of technology in the home. More recently, connected health and medical devices have enabled new services for consumers to monitor their health care. This has come in all sorts of new form factors and with monitoring services. The global pandemic has also greatly accelerated the use of health services in consumers' homes. We have seen telehealth services skyrocket. 41% of consumers have reported using a telehealth service in the past 12 months, 3 times greater than the year prior. We are excited to bring you 3 days of discussions focused on consumer use of technology in their homes and the impact of the pandemic on new services. With the support of these industry leaders in the health and wellness space, we are able to host this event. Thank you to our sponsors for their involvement in our 7th annual Connected Health Summit. We have presentations from visionary speakers throughout our conversations and networking discussions following our panels moderated by Parks Associates analyst team. We want to thank these industry leaders in advance for their time. Tori Ames, Dr. Donna O'Shea, Mark Dunning, Jean Wang, Richard Culberson, Angie Kolausk-Ebrahimi, Dr. Yuri Quintana. Thank you for joining us for Connected Health Summit 2020. We hope you find value in each session and in connections made with other attendees, sponsors, and speakers. Use the question tab to ask your questions or to upvote your favorite questions from other attendees. You can also answer polling questions under polls to give your live vote. Our analysts and panel speakers will be addressing your questions and the polling answers during the live stream. Ask your questions early in the presentation as our analysts will choose the most upvoted questions to be addressed by the session speakers. If you have any questions during the stream about SwapCard, our team is standing by to help. Just drop a message in the chat or message one of Parks Associates team members via the Parks Associates company page. We want to make sure you're connecting with our industry-leading sponsors in the smart home space. You can visit any sponsor during the session by navigating to the Sponsors tab, browse sponsors, or bookmark the ones that interest you for later. Contact the sponsor via chat, view uploaded documents, watch welcome videos, and more. Have you created your personal event agenda on SwapCard? Go to the Agenda tab, view different sessions under each date, add the sessions that interest you to your personal event agenda. You can access your personal event agenda by clicking the My Event tab. Export your agenda to your calendar to receive reminders and a direct link to your registered sessions.
Good afternoon, everyone, and thank you for joining us for the second half of today's discussion, looking a bit more in depth on some of the changes in the telehealth and remote patient monitoring space. I'm Kristen Hannock, a senior analyst here at Parks Associates, and also a medical anthropologist, MS MPH, specializing in technology adoption. As you might expect, it's been a very exciting and interesting year for me, looking at all of the very, very many changes that have been happening across the medical industry as well as among consumers. So again, just to mention, this session is really being made possible by these great sponsors who have worked with us to support the Connected Health Summit as it moves virtual. So again, thank you very much for your sponsorship. For the next few hours, we're going to take a look at really what's changed in the virtual care space. As we're all aware, the market has seen really some massive changes in terms of adoption, in terms of awareness, and also in terms of business models that have really radically impacted the market. I'm going to take almost about a half hour or so to talk about some of these changes, as well as outline the prospects for telehealth and remote patient monitoring in a post-pandemic world. Then we're going to hear from Dr. Donna O'Shea of United Healthcare on some of the trends that United Healthcare has been seeing. We will all be talking about reimbursement and regulation with Kristen Ratcliffe McGovern of Surrender Strategies, as well as David Barden of TitleCare. And then we will be talking about how the landscape of telehealth and remote patient monitoring has changed with Amar Kendale of Belongo, Paul Bryant with Athena Health, and Michael Farrell with MD Live. Finally, we'll end our day with a few networking discussions in private chat rooms. Remember, for each discussion, we're going to be reserving a few minutes for questions from the audience, so make sure to get your questions in ahead of time. If you were here for this day's earlier discussions, there's a little chat box to the right of your screen with Q&A on it. That's what you're going to want to use. And also join us for our networking discussions at 2:45 after the presentation. So yes, telehealth adoption and utilization have really dramatically increased in 2020 compared to prior years. We all really know the reasons why: the ongoing COVID-19 crisis, the shelter-in-place orders from earlier this year, the shutdowns of elective care that happened in many locations, and social distancing, as well as overall reluctance on the part of patients to seek care in person. COVID-19 has really interrupted care delivery for many. In Parks Associates' May survey of 5,000 heads of U.S. broadband households, nearly a third of our survey respondents reported that they were unable to visit the doctor for a consultation or a checkup directly as a result of the COVID-19 crisis. Over 1 in about 10 were unable to undergo a previously scheduled procedure. And as of now, the beginning of September, many of these restrictions on electives have been lifted. Electives have returned. However, there is still that percentage of consumers that are avoiding in-person care due to personal safety concerns. Essentially, this year, many consumers were forced to use virtual care if they wanted to receive care at all. As we shared earlier today, Parks Associates' May survey revealed that 41% of U.S. broadband households reported using a telehealth service of some kind in the past 12 months. So nearly a threefold increase in adoption compared to 2019. Utilization growth was even higher. Many businesses in the telehealth space reported utilization increases of anywhere from threefold to 1,000-fold, depending on the service type offered. This drive to virtual care really came about as a result of a number of different factors. Consumers who were already familiar with telehealth turned to solutions they knew and have used in the past. Employers and insurers also took steps to educate and inform their employees and members on what virtual care options they had available to them, which helped to drive adoption and usage. And health systems and private practices dramatically scaled up their telehealth solutions, or even deployed them for the first time in order to see their patients. In fact, Parks Associates consumer survey data has noted that telehealth services from providers have really experienced exponential growth, becoming the most widely adopted telehealth service type by consumers, surpassing direct-to-consumer telehealth services and services offered from an insurer. So I'd like to ask you, the audience, the same type of question that we asked our survey respondents earlier this year. Have you used a telehealth service in the past 12 months? If so, what types of services have you used? I'll give you about a minute to respond. So actually, I can also tell you a little bit more about my experience with telehealth earlier this year. So yes, I attempted to use a service. I'm not going to say which service exactly I attempted to use, but unfortunately, I, like many consumers, got caught up in some of the very long wait times and then the technical issues. So I believe I waited about 6 hours in line to see someone, and then I wasn't even able to get through. I got booted off of the platform. So yes, it was certainly really a mad rush in the beginning. So I really expect you guys to report some pretty high telehealth service usage overall. Just given the topic of today's conference, I am pretty interested in learning about what type of service you used though. So it looks like you guys have started to respond. We're getting some responses in. So it looks like we've seen a lot of people visiting local care providers, a fair amount of people saying that they haven't really needed to use a service in the past 12 months. So I think I'm going to go move on with the presentation and give you guys a little bit more time to respond and get those answers in, and then we'll circle back around. Okay. For the rest of this presentation, I'm going to take a look at some of the changing trends in the telehealth and remote patient monitoring space from really three different perspectives. From the perspective of care providers, hospitals, health systems, and private practices, from the perspective of direct-to-consumer companies and those serving enterprise clients, and also from the perspective of consumers themselves. And then I'm going to talk a little bit about the regulation and reimbursement changes we've seen, and really what this means in terms of what we can expect from a post-pandemic world. Prior to the COVID-19 crisis, many care providers and health systems were really reluctant to try virtual care solutions for ambulatory care. This is for a number of reasons. A lot of clinicians wanted to see their patients face to face, lay on hands, and also be able to take standard vital sign readings, measure weight, blood pressure, pulse, breathing, look really with their own eyes at the patient's skin or ears or eyes. Many also had bad experiences with some of the early health tech solutions that really just added to administrative burdens instead of alleviating them. There was also a fear of the unknown and of trying new things, a question of whether it would be worthwhile, and also concerns and hesitations about the business models. Earlier this year, care providers and health systems were not able to see many of their patients in person. Their choices were either to shut down operations, furlough their staff, take the revenue hits, and lose track of their patient populations, or to deploy telehealth solutions at scale and make use of virtual care and telehealth to the fullest extent possible in order to try and recoup some of that lost revenue, which, as Jennifer mentioned earlier, is estimated at roughly $323 billion. Many chose the second option, rapidly scaling up telehealth solutions across departments and really doing in a month that what would normally take a year or more to plan and implement. Systems and providers that already had deployed telehealth in some form or fashion were able to lean on their existing partners to rapidly scale their ambulatory telehealth offerings. Their internal telehealth teams and steering committees worked to thoughtfully implement guidelines and train clinicians. However, those without existing partners and expertise were forced to turn really to just a hodgepodge of consumer solutions, such as Facebook Messenger, FaceTime, and Zoom, made possible by the temporary non-enforcement of HIPAA. They moved fast and broke things, and many are now in the process of cleaning things up. As a result of this widespread rollout, many more stakeholders have gained an understanding of how telehealth works, as well as really what is needed in order to do it well. However, what we expect to see coming, and actually what is already beginning among these health systems, is a thoughtful evaluation of their needs, workflows, and what technology and solutions can really best support those needs and workflows after their rapid forced adoption. Among clinicians, there is also a recognition of what video visits are missing and can't do, namely get vital sign data from patients. Integrations with connected medical devices will also become increasingly important as time goes on. Patients will either need to buy their own equipment or get it deployed to them via their care provider or insurer. The systems and providers that deployed a hodgepodge of technologies, FaceTime, Zoom, and others, need to really figure out a viable solution for telehealth going forward. They cannot continue to rely on these technologies in the long run. HIPAA will eventually return. And many of these solutions, well, all of these solutions, were really not designed to meet the needs of care providers and healthcare administrators. They will either need to stop offering telehealth or find vendors and deploy telehealth solutions that were really designed as such. Systems who leaned on their existing vendors are also likely to reevaluate their current vendors and carefully select a solution that fits best. There are a lot of sales conversations going on right now. Just expect that to continue. Speaking about companies on the telehealth and remote patient monitoring side of things directly, demand has really been enormous. This includes demand in the direct-to-consumer side of things, as well as demand from businesses and insurers to take care of their populations. I already talked a bit about demand from care providers and health systems. The percentage of consumers seeking treatment in all areas grew. However, there has been an increasing amount of interest in a few areas in particular. Mental and behavioral health has definitely grown, as has the use of telehealth and remote patient monitoring for chronic care issues. Something particularly interesting is the emergence of what is called virtual primary care. The ability to use a combination of virtual visits, connected health devices, and partnering with labs for diagnostic testing in order to not just replicate the in-person primary care experience, but also to offer a tech-first solution, really bringing together a whole care team on a single integrated platform. The ability to have lasting relationships with physicians on virtual care platforms eliminates one of the big barriers to telehealth adoption among consumers, and also stands to significantly shake up the healthcare landscape. And speaking of barriers, on the consumer side of things, we've seen some of the largest barriers to telehealth adoption really just go away. Two of the top things holding the industry back were a lack of awareness and familiarity, preference for an existing care provider, and also the third thing, among many, a general belief that the in-person experience would just be better. What we've seen is that there is now much higher awareness and familiarity. People who were already using telehealth services recommended them to their friends and families earlier this year and continue to do so. Workplaces and insurers successfully reached out and engaged with their employees and members, educating them on the options available to them. Many people were able to reach out either to their existing care provider via telehealth, or they found new care providers. One of the other big shifts we've seen is that now virtual care is also really being seen as better than in-person care. Currently, this is largely due to safety issues. People are concerned about getting COVID. Many are also reluctant to come in for in-person care entirely, and they want to do remote visits as they're no contact and less safe. Another interesting trend we've seen are the changing demographics of telehealth users. Historically, the core user base has been the tech innovators, young, tech-savvy individuals, many of whom are also parents. This group is still the core. However, we've also seen a massive growth in non-core users as well. There was a massive upwards tick among seniors in particular, many of whom were using Medicare. The Centers for Medicare and Medicaid recently released research data on telehealth service utilization. They reported something on the order of 1.7 million telehealth video visits billed to Medicare in the month of April 2020, up from a monthly average of only 52,000 prior to COVID. That is an astronomical increase in utilization among Medicare population. In terms of the percent of seniors overall making use of telehealth services, Parks Associates consumer survey data shows an increase in adoption of around 400%. Last year in the second quarter, roughly 6% of those age 65 plus reported using a telehealth service in the past 12 months. This year, that percentage grew to 29%. So looking at another factor, we surveyed consumers as to their likelihood of using telehealth the next time either they themselves or a child in their household was sick. Over 40% said that they were either likely to or would definitely use telehealth in the future, rating their likelihood a 5 to 7 on a 7-point scale. A consumer's level of familiarity with telehealth is really highly correlated with that consumer's likelihood of using it in the future. We tested consumer familiarity with telehealth on another 1 to 7 scale and found that only around 8% of consumers who were unfamiliar with telehealth considered themselves likely to use it the next time they or their children are sick. When familiarity starts going up, that self-reported likelihood rises dramatically. Among those very familiar, only over 2/3 report that they intend to use telehealth the next time they or their children are sick. Before, I talked a bit about consumers becoming more familiar with telehealth solutions. Many were educated on their options by friends and family, their employers, their health insurer, their own care providers. However, Parks Associates consumer survey data finds that only about half of consumers consider themselves familiar with telehealth, and just less than a third consider themselves very familiar. There's certainly room to grow with regards to educating consumers, and as this level of education increases, so will demand. Quite a few consumers who have used telehealth services in the past fully intend to use them again. This is a very promising sign for permanent telehealth increase in a post-COVID world. I should also mention that consumers aren't just interested in remote video visits, but also interested in really all types of virtual health solutions. In May 2020, we found that consumers reported high intentions to purchase tested connected health and connected medical products, such as wearables, Wi-Fi weight scales, connected blood pressure cuffs, and smart thermometers. On a similar vein, consumers report high levels of interest in telehealth services that would allow them to share data from connected health products within their homes, or from apps and platforms such as Apple Health and Google Fit. And in fact, an increasing number of telehealth companies are offering just this type of functionality. Behind these trends, increased adoption and utilization by consumers, widespread rollout by health systems and private practices, Increased demand for mental and behavioral health, chronic care, and virtual primary care, as well as demographic shifts, is expanded reimbursement and widespread regulatory changes with regards to telehealth and telemedicine. We saw recent changes in 2019 and 2020 by CMS really pave the way for virtual primary care, the use of telehealth to treat patients with chronic conditions, and the use of remote patient monitoring services provided by vendors. Other changes have included payment parity with in-person services and the expansion of fee-for-service coverage to hundreds of additional services. This has, of course, led to changes in business models. Things that were technically possible to do years ago but were not profitable or even hurt profits now actually make business sense to implement. On the regulatory side of things, we have likewise seen a number of changes. Medical licensure restrictions were relaxed or waived by a majority of states. As some of that has gone away by now, some of it remains. CMS restrictions around where telehealth visits could be conducted were also waived. Patients no longer need to go to an originating site to receive care. Instead, they can now receive care in the comfort and safety of their own homes. As I briefly touched upon before, one of the largest regulatory changes was the temporary waiving of HIPAA requirements for the duration of the public health emergency. I mentioned before that there had been a massive boom in adoption of telehealth services from local providers. While providers and health systems turned to their existing partners to rapidly scale their offerings, those without those systems in place turned to a hodgepodge of consumer solutions like Facebook Messenger, FaceTime, and Zoom, made possible by the temporary non-enforcement of HIPAA. I'd like to reiterate here that one of the things that we can expect to happen over the coming months and years is providers and systems figuring out how to get out of that hodgepodge and implement telehealth in a way that is compliant with HIPAA, that works with clinician workflows, and that doesn't add to administrative burden. This is really a massive opportunity for vendors to get new conversations started and seek out new partnerships. Of course, the COVID-19 pandemic remains ongoing. Our most optimistic timeline is that we have a vaccine ready to go and available to the public somewhere around April of next year. Realistically, however, it looks like we may be living with COVID for a year or 2 years, or potentially permanently, depending on what happens. As COVID will continue to be with us for a while, stakeholders in the healthcare space need to make virtual care, telehealth, and remote patient monitoring part of their long-term strategies. In the months leading into this conference, I had the chance to talk with a number of innovative health systems across the US. Many are planning on permanently boosting their telehealth usage and are making the internal changes necessary for doing so. Once these changes are in place, they will be difficult, if not impossible, to roll back. Rip and replace is very expensive and time-consuming on the part of health systems. And once clinicians have had the chance to become used to their new workflows, and hopefully the new efficiencies and reductions in paperwork, they will be reluctant to change them. Another factor, I was just talking about increased demand from consumers and businesses. This is really only going to continue as time goes on. By the time the pandemic ends, in 6 months, a year, 2 years, virtual visits and telehealth will be normalized. People will be used to the convenience of a video call, a phone call, or a text message, to using devices in their home to take vital sign readings and sharing those with their physician online. They will not want to call the doctor's office, make an appointment a month out, take a half day off of work, and sit in a waiting room for an hour just for a 10-minute conversation with a physician that really could have just been a phone call. For consumers and businesses, there will be no going back unless they have no other choice. As of now, at the beginning of September, there are still a number of uncertainties around business models and regulations. The business model piece is critical, as that has historically been one of really the major things that has been holding telehealth back. A promising sign is that CMS is moving to make a number of its emergency measures permanent. As CMS has historically been used as a model by private payers, we can expect that the employer-based insurance world will follow. However, questions still remain around which services will be covered, as well as around payment parity. Which services will be reimbursed at what rate? On the regulation side of things, there are uncertainties around the requirements for originating sites, requirements for having a prior relationship with a patient in order to provide certain types of care, requirements around care modalities. Audio only is a modality that many consumers prefer, but historically it has been difficult to get reimbursement for an audio only visit. There are additional uncertainties around when HIPAA enforcement will return. as well as the accommodations around medical licensure, the waiving of state-specific licensure requirements, the issuing of emergency licenses, will all entirely run out. Again, some of this is already beginning to run out. This confusion isn't just on the part of CMS requirements, but also in terms of state law and laws with different territories and regions as well. So over 50 different patchworks. One of the biggest challenges stakeholders will have over the coming months is going to be figuring out how to make long-term plans in this uncertain environment. We will be getting into this topic in a little more detail in our upcoming panel on reimbursement and regulation a bit later today. So we expect to see a continuing need for telehealth and virtual care, continued demand among consumers and businesses, and increased rollouts by health systems. The regulatory and reimbursement side of things is uncertain, but looks promising. However, there remains a few big challenges ahead of us. Patients who are avoiding in-person care, but also not making use of virtual care or other types of remote care solutions, are going to experience issues, increasingly in the months and years ahead. While there are certainly some patients whose needs cannot be met with virtual solutions, there remains a large segment of the population who are unfamiliar with virtual care and don't understand what avenues are available to them. They are not engaging with the telehealth system at all right now. We don't know for sure what is going on with this population. However, we can look to research conducted on care avoidance in general for guidance. We can expect that lower numbers of prenatal care visits among pregnant women will result in correspondingly higher numbers of miscarriages. We can expect that people with severe chronic conditions who are not making check-in visits will have worse health outcomes and may require hospitalization in the future. We can expect that people who are not undergoing diagnostic testing for conditions like cancer or heart disease will have their diseases progress without proper care. If we are in this for the long run, and we are, then more needs to be done to engage with this patient population and get them the care they need. If care cannot be provided virtually, then we need to figure out ways to either bring them safely to their care teams or bring their care teams to them. There's also another big challenge. According to Parks Associates estimates, roughly 87% of US households, have internet service via a home internet subscription or via a mobile service to a smartphone or tablet. That leaves 13% of US households, around 14 million households in total, unconnected and unreachable by app or web-based solutions. Many of these households are older or lower income, the Medicare and Medicaid populations, the groups generally more likely to have health issues. There is a need for solutions targeted to the unconnected population, especially configured smartphones or tablets, connected health devices with embedded cellular connections or a connection to a hub, solutions that do not require that the consumer provide the internet connection. Solving these issues will likely fall to payers and those who work with Medicare and Medicaid populations. Okay. So I have one more polling question for you all, but first I'd like to circle back to the answers that we had for our first polling question, where I can see that it certainly looks like most of you guys had the ability to visit your local care provider, and that is the care modality that you've really preferred. So that really also jives with our survey data. We saw just really a huge shift in the market with most people engaging with their local care provider. Okay, and then going now to our current question, I'd like to know what you, the audience, think of as really the biggest challenges the medical industry will face in the year ahead. So we have a few different options, getting patient visit volume back up for non-COVID care, resolving the logistical issues related to telehealth rollout, preparing for the fall and winter demand that is likely about to be here, figuring out how to reach those underserved patients, protecting medical workers and staff from COVID, and also staffing and other challenges not listed here. It looks like a number of responses have come back, and quite a few of you agree that one of the really big challenges is going to be figuring out how to reach those underserved patients. And also another big challenge is going to be resolving all of these logistical issues related to just that rapid scaling of telehealth. So yes, thank you all for participating, and I believe I have a few minutes left to take some questions from the audience. Yes, do I know of, looks like a question came in, do I know of any systems which combine remote patient monitoring, telehealth, and social we're seeing some development in that space where a lot of different players in the market are looking at combining some of these factors. One of the biggest crossovers is remote patient monitoring and telehealth. So we had TytoCare talk a little bit earlier today, and they're also going to be joining me a little bit later for another panel discussion. So that's one of the biggest. In terms of telehealth and social, we've seen a few very innovative insurers start to combine some of the telehealth and social aspects through digital therapeutics and other means. So working, again, a lot of times with that underserved population. So you're going to be hearing from Blue Shield of California on Thursday. So you'll have a chance to learn more then. It looks like another question came in. Where did the research come from? What parts research is available? So yes, a lot of this research came from this big study we ran back in May of this year. We surveyed 5,000 heads of US broadband households, asking them a number of questions around their telehealth use, COVID use, COVID-19, different factors, such as if they were working remotely, what had happened maybe to people that they knew, what their concerns were about elderly family members, and also how they were reacting to the crisis in general. So lots of questions along those lines. We regularly do surveys of US broadband households, so we tend to drop in every quarter and sometimes a little bit more frequently. Okay, so yes, regarding underserved patients, you're interested in hearing about some of the most promising digital initiatives that I've really come across. So I've been hearing some very interesting things about insurers really working to engage with this population by deploying devices. So lots of times they will actually deploy tablets and smartphones and other devices that have been pre-configured with apps. And they are also offering coverage of the data connectivity themselves. Some of this is sponsored by CMS. This is, again, largely to Medicare, Medicaid patients, CMS and also the states. I believe there are also a number of partnerships going on with some of the telcos. I want to say Verizon, but I'd have to take a second look, make sure. So do I believe that healthcare is going to move more virtually than in person in the future? I think it depends on exactly which field you are talking about and discussing. So there are certainly a few different fields where the virtual experience is seen as kind of actually preferable to the in-person experience. I think behavioral health in particular, there's a huge amount of potential in terms of virtual solutions. Some other areas, maybe not necessarily. It really does really depend on a case-by-case basis, and in terms of looking at what type of care is needed, and then really the best way to engage with the patient. Okay, I think we have time maybe for one more question, and then we're going to have to jump to our next next. Okay. Okay. So I guess this is really about everything, unless anyone else has another question. Well, I would certainly like to thank you all for joining me for this discussion this afternoon. And I am looking forward to hearing a bit more from all of you as the day really progresses, and also in our upcoming conversations at more towards the close of the day. again for joining us this day as we look at some of the many changes we've seen in the telehealth and remote patient monitoring space. So I'd like to turn things off, turn things over to Dr. Donna O'Shea, Chief Medical Officer of Population Health Management at United Healthcare, for her visionary insight on really the explosive growth in telehealth and some of the trends UHC has seen.
Thank you so much. I am going to, hi, put on my slides here. I know they were just up. So I assume they're here now. I'm going to talk about the rise of telehealth in a health plan perspective, and you can help me if you don't see them.
Okay, we'll figure it out.
Okay. So, so first I'm going to talk about first I hope you can see them, so I'll just keep going here. I'm going to talk about our perspective from United Healthcare. I'll cover 4 different areas. I want to talk a little bit about what happened with COVID-19. Then I'll move into the digital, talk a little bit about digital responses and virtual care, do a virtual care overview, and telehealth adoption and satisfaction, what we're seeing, and then end up with a little bit on behavioral health telehealth services. I probably should have started a little bit with.
Oh, sorry, Don.
Yeah.
Can you change your presentation to be full screen? I think we're only right now seeing just kind of the pop-up.
Did that do it?
I think we're seeing the wrong screen potentially.
Okay, well, let me, I can do it this way, and then you can tell me. How about this?
Yes. Yes.
Awesome. All right, we're starting now. Okay, so I should have started with Dr. Donna O'Shea. I'm the National Chief Medical Officer at United Healthcare. I work with population health, and in terms of population health, I work with our provider partners, as well as do some population health initiatives, which right now immunizations is one of the big topics, and then of course telehealth. So I'm really happy to talk to you about what's changed at United Healthcare, and give you the health plan perspective. So as I mentioned, this is my agenda. I won't repeat it again, and I will go on to the next slide. I think when the COVID-19 hit us, that was really a tipping point, and we had been really active in the telehealth space with our local providers. However, most of our telehealth experience for our United Healthcare members came from our national providers, and in fact, we were struggling to have our local providers offer services to their patients, and we were looking to move away from to expand so that our members could use a national provider or could see their own doctor for chronic care services. And the interesting, and we had a lot of large practices interested, but it was really hard to get docs really enthused about telehealth. There were a few hot spots, we're doing great work, but really in terms of in January of 2020, we were not sure how many more provider groups would be interested in really moving on in the telehealth space. So then, and we had been listening, but then the COVID-19 public health crisis began. So we really had to, people started to come to us looking for information with facts, resources, and insights about what's happening with COVID-19. And they were really counting on us to, now that they couldn't see their doctor in person, what could they do? And their providers, like, if I can't open my office, what am I going to do for business? And so we listened, and we had experience in the telehealth space. And so we started to educate our members as well as our providers. In fact, within that first month of March, we had several webinars with thousands of our partner providers attended to learn more about how can I get telehealth up quickly, how can I serve my, how do I do it, how do I engage my patients, and how do I get paid for it? And so that was really well received, and this really gave them the power to really continue in practice and to see the patients that needed to be seen. Now, we also, of course, have in the COVID-19 space, we have to have other digital resources. And so we have, other pieces we rolled out to our members. All of our members, just as an aside, so all of our members have a digital option. And when I say digital, for most of our members, it means a telehealth, national telehealth option. That was pre-COVID. And so that was available. But we also, when COVID-19 came in, we realized we had to have more information. So they had to have readily accessible information on symptoms. And we have a symptom checker. How do you know if you have COVID-19? What are some of the risks? How do I know if I need to go to the doctor? And earlier it was mentioned, when COVID-19 first hit, if you remember, the telehealth waits, 6 hours was not unusual. We were not ready for those patients. And so this at least helped patients to triage a little bit about, did they really need to get into that kind of a line? We did have access to our national providers, and throughout March, we were able to help a lot of our other providers get set up to see their patients virtually. And when we get to where we are now for virtual care, we have to think about it in several different buckets. There's a lot of terminology, telehealth, telemedicine, telemental health, that gets thrown around when we're talking about the space of telemedicine, of digital medicine. And so one of we're trying to work on is really some standard vocabulary, but I'll tell you a little bit about how we're doing it and what we had before and what we're seeing now. And so when we first started in telehealth, and so as I mentioned, in 2019, most of our virtual visits, our real-time visits with doctors and patients, was through what we would call urgent care, or the national telehealth partners that we have at United Healthcare. And we do try to make it easy for our members, and we do have apps on the phone, and or you can get online, and it's integrated with our My UHC platform. So we make it easy. And most of those visits were really for those urgent care visits. Those, I have a red eye, I have a rash, I have a fever, sore throat. So those were those urgent care with national telehealth providers. Around 2017, we started talking to our local providers to try to get some of our local providers interested in providing it to their patients for same-day services, maybe, but also for chronic care that, people patients wanted, our members wanted more access, easier access to see a doctor, to see their doctor. And so we started building that relationship with these partners to offer it to their members. Now, of course, and we'll talk about the numbers in just a minute, but now, of course, most providers have needed to embrace the concept of telehealth for all their patients, for all different kinds of problems, because of COVID, because patients don't want to go to the office. If we look at specialized care, some of you might even remember, there's a lot of pieces that fall into specialized care. The most commonly used one, of course, is behavioral health. And behavioral health has been, widely accepted and into this framework of telemedicine. But specialty health, specialists have grasped onto telehealth with great success. Dermatology is a classic example. There's second opinion or expert opinion sites as well. And then there's also, room still out there for, and this happened again early in the pandemic, where occupational therapy, speech therapy, physical therapy, people will still have to have their rehabilitative therapies during this pandemic, and they couldn't go. And so that was also more commonly used during during the social isolation. And now, of course, we're moving into continuous care or remote patient monitoring, and that's been around for a while in different ways. When I talk about this, I'm really talking about devices that connect to us as a health plan. So we have some programs for our highest risk members, but also devices that connect to your doctor who's tracking you for some of your complex health needs, like heart failure. What's your weight doing? And they can track it and track your blood pressure or some musculoskeletal symptoms, and get in touch with you before the problem gets so bad that you need to go to the hospital. So that's a really exciting space that we're moving into. Some of you have heard about remote monitoring for COVID, especially with discharge. Some hospitals are doing that. So I think that's an expanding space. I think we're just moving into that. I think virtual visits is the first major expansion there that we're seeing. And here's some numbers on that in terms of the adoption and the high satisfaction. We have seen, this was in the second quarter of 2020 at United Healthcare. We had a 10-fold increase in telehealth visits, looking at all of 2019 compared to the first quarter of 2020. So huge increase in telehealth visits compared to the previous year. And now we know that our visits are not just the disproportionate national versus local in 2019 is gone. And in fact, we have now many more visits from local providers with their own patients. 60% of people said that COVID has made them more likely to try telehealth in the future. So we know COVID-19 is certainly a tipping point. And 73% of telehealth users said they were either very likely or likely to use the resources again after they used it once. So that's a high measure of satisfaction. And this is all ages, and we certainly have a large group of Medicare Advantage members that use telehealth. This one is the healthcare resolution on the first visit is really an important number, because there are still some people that are concerned that telehealth could actually result in an increase in healthcare costs. And we all know that today we can't take on any more increases in healthcare costs. We really have to drive healthcare value up, and that means driving cost down and quality up. And so it's wonderful that 81% of the telehealth users had their healthcare need resolved during the first remote visit. And we know there's savings with telehealth, looking at several different studies. Some people would say up to $120 for each telehealth visit. Of course, it's going to be hard to say where the savings is in the future, because, I think all of us probably agree that a telehealth visit is going to be just part of a way to have a healthcare visit, that it's not going to be any different. At least we believe that's where it's going. I mentioned in the beginning that we had, providers were really the toughest people to move along the telehealth spectrum. Patients were ready to jump in, and providers were like, "Whoa!" So we're happy, to say that that's really changed, and that nearly 50% of this is from a study nationally. 50% of physicians are using telehealth technology in 2020, which is really up from 18% in 2018. And they're coming to like it. 93% of physicians using it, and it really does improve care access, and they're going to continue to use it. And so, in terms of our own network, I mentioned we had provider groups, some provider groups that were interested, but in 2019 we had 14,500 distinct healthcare providers that furnished at least one telehealth visit, and many of them it really was just one telehealth visit. But so far in 2020 we've actually now gone over this number, over 265,000 distinct care providers furnishing telehealth visits, and now many of them are, once they do one, they do more. I think when we were first rolling telehealth out before COVID, most of our providers said they had to do between 3 and 5 before they felt comfortable. And I think with COVID, they've had ample opportunity to do 3 and more. Now, behavioral health. Behavioral health has really been, it makes sense and a lot. And in fact, when we talk about behavioral health, there's several different paths that we can talk about behavioral health. We have behavioral health services, and so or supports, and it's you can see here 43% of our employees added new mental health supports for remote employees. Now, those may not be a live person, it may not be an appointment, but there's a lot of behavioral health apps and sort of apps that then will connect you with help available now. And of course, that's just really taken off. We also know that in terms of behavioral health, that often the primary care providers write most of the depression prescriptions or ADHD or anxiety related prescriptions. And so on regular telehealth visits with primary care, often those are behavioral health type visits. But then there's also behavioral health services from a behavioral health provider, including psychiatrists. And this has really helped the behavioral health space, particularly in our setting of very limited supply of psychiatrists. So we know that some of the behavioral health services, because across lines, and you can get to see a psychiatrist much more quickly than you can in person, really. And so this has been greatly taken up by the patients. Patients say that it's so much more convenient, and they feel it's so much more private, that they can talk privately, and maybe some of that, they feel a little more at ease. There's a little bit more distance to open up and share things in a space that's really comfortable for them. So it's a great service. More employees, 71%, are accelerating their adoption of telehealth and virtual care services this year. Over 50% will offer more and different options over the next year, and many will have a special telemental health services, which may also be a telemental health benefit package, which might be different for some of those employer groups. And over half of them want to decrease or waive the costs for telehealth in 2021.
Thank you, Donna, for that really wonderful talk. I believe we do have a few minutes left for Q&A, and we actually have some questions in the audience.
Okay, great.
Okay, so first off, would you be able to comment on United's acquisition of Vivify and how the Vivify has been deployed in order to really move into that continuous care component of telehealth?
Yeah, so Vivify is a great, I can speak a little bit about it. I'm not involved exactly with all the plans around Vivify. I will say that we're trying different things with Vivify. It is a relatively new acquisition. We are using it ourselves for one of our lines of business to try to take care of our highest risk members with our own care management team, and how does that work? And so I think that's our first foray. We're also looking at how to deploy it in with providers or for providers, and that's still a work in progress. I think there's as I said, we're a little bit early on. I think initially we thought there'd be more patient uptake. It's not quite as much as we had anticipated, but it is still early, and it is a funny time to be bringing on any new projects with the COVID-19 situation.
Okay. Then I have another question for you from the audience. So how important is clinical validation and FDA clearance for the devices being used for remote patient monitoring? What kind of criteria do you use for data validation and analytics for the data from these devices, especially in remote patient monitoring for chronic conditions, such as heart failure, COPD, kind of post-COVID monitoring as well?
Yeah, so there's a lot of different monitors and a lot of different, I'll say there's a lot of different devices, a lot of different monitors, and a lot of different parts of health a person has to monitor. So in some ways, we've been using healthcare monitors for quite a while. Years in terms of, for example, CHF. We have had a heart program that would be able to provide a Bluetooth weight scale to the member and blood pressure cuff. So we've had those kind of programs in place for our highest risk members, and they've worked great, and patients really appreciate them. And we have, and we've had to be certain that the data would be able to come to our systems, because we do, need to monitor those. And I think that's where the device situation comes from. So depending on how one would be using the devices, if you're in a provider group, are you going to monitor them, or is someone else going to monitor them and send you the data, or send you when something needs to happen? I think there's a lot of different pieces to then it's not as simple as just putting on your watch and measuring your heartbeat, because when we do this, we need to make sure we're tracking with the patient. Before I'll say, in general, before one would move to, there's so many devices, one really needs to examine not just the device, but also the connectivity. Does it connect in your EMR, or does it connect? How does it connect? And do you have a place to store it and a place to see it?
Mm-hmm. That's definitely all very, very good questions. So I have another question from the audience. This time talking about maybe some of the billing challenges that care providers have been running into. Can you speak to some of the challenges organizations may have had with coding and documentation of the treatment given that a lot of visits were done via telehealth instead of in person this year? I know some of the billing codes might not have been updated. Other challenges.
So early in the year, well, I think billing challenges are going to continue to be a little bit of a change over the next year, only because I think there are different dates of when certain things are covered for what, especially when you start throwing in the co-pays that are waived for COVID-19, but not for diabetes, or so there's a lot of challenges in, I'll just say, co-pays. But in terms of the billing, the expectation is still that there is, there still needs to be record keeping, and the record still has to be consistent with the level of the bill code of the code used. And I guess I may not be. I don't know that I'm certain exactly what the question is, and so I know that I'll speak for United. We had to change a lot of systems to make sure that we paid for these visits that were virtual visits. And, we committed to pay for those as virtual visits, whether it was in your contract or not, let's say. And so it took a little while to get through the system. And I think I think are caught up there. But I think one of the providers, questions will be questions is, well, what's going to happen going forward, and will I still bill in the same way? Because with COVID, we were very accepting of many different ways that people were billing, and we're trying to get to a standard place now. And so with time, hopefully all the health plans will come together to one standard place, but it was really hard initially. And so hopefully, anyway, I'll leave it for more questions, but hopefully you recognize that the bills should be paid by now. And but if you're still having trouble with billing at this point in time, it's probably best to go right to the health plan, because it's probably health plan specific, since there were many different rules out there for different health plans initially. And it's only now that we're able to come together a little bit better. And I don't think we're there yet either.
Yes, I think when I've heard of it myself, and it sounded like a number of the smaller providers were having difficulty getting paid just because of all the changes being made. So hopefully that's mostly resolved by now.
Yeah, we had a lot of, we were accepting a lot of like re-bills or looking at them because a lot of them just came in. The poor providers. I know many of them just didn't know how to fill out a claim for telehealth, and that was one of the reasons we even had the provider webinars to help with that.
So I think we should have time for one last question before we need to move on. So can you talk a little bit about the Apple Watch promotion that you've had where members can walk off the watch cost? How are you really integrating telehealth and member engagement using the Apple Watch?
That's a good question. I wasn't involved in that particular project, so I don't know. I wish I could tell you. I don't know how many engaged in it. I know it was patients were really interested. I think I'm just not sure of what exactly the follow through was. How many stayed engaged and things. I'm sorry.
Okay, well, maybe we can try to do a follow-up after the event and see if there's anything out there publicly that we can send to our attendee who had that question.
Okay, that'd be great.
Thank you, Madonna, for wonderful and for joining us for this event. I think we all learned a lot. And now we're going to reconvene in about a minute or so for our next panel, looking at the topic of reimbursement and regulation change.
The COVID-19 pandemic has thrust virtual solutions to the forefront of healthcare. Sweeping regulatory changes, combined with changing consumer preferences regarding in-person versus remote care, have created an enormous shift in the market and very quickly. In the past 12 months, 41% of U.S. broadband households used a telehealth service, nearly tripling year over year. Further, 83% of consumers who use telehealth services had their most recent telehealth visit paid either completely or partially by insurance. Consumers consistently report preferences for local providers for virtual consultations, and the market is now meeting that demand. In Q2 2020, 46% of recent telehealth users report using a service offered by a local physician's office versus only 13% in 2019. The industry now needs to expand providers' ability to collect and integrate data from a wide variety of connected health devices, to deepen the provider's understanding of patient needs and expand the issues that may be addressed via virtual care. We look forward to sharing more data and insights at our upcoming Connected Health Summit, Consumer Engagement and Innovation, our virtual event September 1st through the 3rd.
Thank you for joining us, everyone. And now let us turn to the topic of reimbursement and regulation in our next panel discussion with a few experts in the industry. So yes, in case you just tuned in, I'm Kristen Hannock, a senior analyst here at Parks Associates and the moderator for this panel discussion. As discussed earlier, one of the main barriers holding telehealth back has been reimbursement. This year, that has largely gone away. Reimbursement has been just massively expanded. Many regulations that have in the past held back the adoption of telehealth have also gone away. However, as of today, we're not really certain the extent to which the recent changes will be permanent. So there are a lot of questions around what this really means for everyone in the industry, and that's what we're going to try investigating today. So I have with me a few experts to discuss some of these recent changes. If you were here several years ago, you may remember Kristen Ratcliffe-McGovern's excellent presentation on reimbursement changes. We were able to get her back again for a follow-up on the many, many changes that have happened in more recent times. We also have with us David Barden, VP of Enterprise Solutions at TytoCare, who can speak from the perspective of an innovative company pivoting rapidly to address the changing environment and also the needs of its clients. So yes, I think, Kristen, are you there? Oh, Kristen, I don't think your audio is on. Is it working now?
Let's see. Can you hear me?
Yes, I can hear you now.
Great. Thanks, Kristen.
Yes, so thank you for joining us today. Kristen, can you maybe start off by telling us a little bit about yourself and about Sirona?
Sure. So Kristen McGovern, a partner here at Sirona. I think for purposes of today's discussion, really two of our activities are most relevant. We are a DC-based lobbying and consulting firm, and my background is really in federal policy with an emphasis on health IT. So I was chief of staff at the HHS Office of the National Coordinator for Health IT, and I was also in the government and the Office of Management and Budget. In the private sector, I really focus on both more traditional health IT, which includes EHR and interoperability, but our firm also runs two initiatives. The first is the Alliance for Connected Care, which is an advocacy coalition around Medicare reimbursement for telehealth and other types of virtual care technologies. And then the second is the Health IT Leadership Roundtable, which brings together stakeholders from across the healthcare system, so patient groups, payer groups, clinician groups, hospital groups, technology groups, to make cross-sector recommendations related to healthcare policy. And we recently held an event and released a white paper on virtual care. So that's a little bit about my background and the experience that and thoughts that I'm bringing to the panel.
Okay, thank you, Kristen. And then next up, David Barton, VP of Enterprise Solutions at TytoCare. David, can you tell us a little bit about yourself and about Tyto?
Yeah, Kristen, can you hear me okay?
Yes, I can hear you.
Perfect. Well, hi there, everybody. My name is David Barton. I lead Enterprise Solutions at TytoCare. I've been with the company now for roughly about almost 4 years, coming up on 4 years, and bringing and commercializing our product here into the US. We, as a company, have an all-in-one medical device that pairs with a virtual exam, going beyond the means of audio and visual, giving the power to patients, for example, in their home to examine their heart sounds, lung sounds, look inside their ears, their throats, gather their temperature, and ultimately send that to physicians, clinicians, either through synchronous means, through a live visit, or through asynchronous means, and either cross-launching into a live visit or sending it across for a later review. I'm thrilled today to share a lot about our growth as a company, but also the challenges we faced and all of the exciting new changes around reimbursement and how that's ultimately helped our organization and the general healthcare industry and covering the costs around these types of visits.
Okay, thank you, David, for that great introduction. So we're going to spend the next 20 minutes or so discussing regulatory and reimbursement changes and the changes that we've seen this year, and maybe also a little bit about the changes that occurred in 2019. We'll try to save a few minutes at the end for Q&A as well. So everyone, remember to get your questions in early if you have any. The place to ask about them is to the right of your screen on swap card that says questions. So yes, I'd like to start things off with a brief Ask the Audience polling question. So I would like to know really which changes in reimbursement do you feel are the most promising? So as those responses come in, I'll go kind of straight to the panel, then we can circle back around to maybe look at some of these responses and see if anything is surprising or about as expected. So yes. So let me start off by asking a question directed to Kristen, and then we'll check in for David's perspective. So what changes in reimbursement do you really feel are the most impactful to the industry, the healthcare industry as a whole right now? Anything in particular?
Yeah, so I think, and you sort of set the stage with your slides and discussion earlier, but there have been many changes to the in the regulation front. I think one of the most impactful, if not the most impactful, was action taken by Congress to lift the originating and rural geographic restrictions in Medicare. So certainly Medicare, there are many patients that have coverage outside of Medicare, but Medicare does set the stage and set the policy tone that others sometimes follow. So until now, there have been really strict restrictions in Medicare that have really limited the use of telehealth. You had to be, as a patient, you had to be in an originating site, which was defined as a facility. So you had to actually go to a facility to then connect in with a clinician in another location. They waived those restrictions for purposes of the public health emergency, which has really opened up. I think we heard some stats earlier, but it really opened up, 1,000-fold increase in telehealth visits at the height of the stay-at-home orders and when people were really staying at home. So I'd say that that's, there are certainly other very significant changes that have been made, but in the Medicare program, that has been hands down the most significant.
Okay, then David, what is your perspective?
Yeah, I completely agree. I think in general, we've found that in the industry of healthcare, the changes that CMS kind of makes really lead the way to the private payers and insurers. And so I think along with a lot of the comments that were just made on the CMS side, Medicaid, Medicare Advantage, changes, we're also seeing quite a few changes happening on the private payer side as well. So in the last presentation, I think you heard it firsthand from United directly on some of the direct changes they're making, covering the cost. I think BCBS in June, pretty recently, they announced that they're actually doing payment parity for, what otherwise would have been an in-person visit, which is a tremendous accomplishment. I think, the fact of the matter is, the changes we're seeing today are changes that likely would have happened over several years. They happened in a series of months. So I'm really excited about, not only the changes that CMS has made, but also the continued changes that the private payers are making to really make it easier for patients to access care. This is the first time that, insurers are treating in-person visits the same way as a telehealth visit. So it's a major accomplishment. And we as a company are thrilled to be on the forefront of a lot of this, to replicate a lot of what can be done in an in-person exam, listening to the heart sounds, lung sounds. So, that's always been the key concern with telehealth is, are we compromising care? Are we compromising quality? And so, we have a major focus on that component, and our biggest champions are truly the physicians and the clinicians. So we're really happy about a lot of these changes. But of course, a lot of it, has been expedited, and even our timelines have been expedited, giving us the opportunity to continue to focus on more clinical components that we can bring forth into people's homes.
Okay. So yes, thank you. So looking back at the survey question we asked a few minutes ago, asking the audience which reimbursement changes they feel are the most promising, it looks like a lot of our audience members are very excited about reimbursement for remote patient monitoring services provided by vendors. A lot are also excited about more specialties and specialists eligible for telehealth coverages. I think there are certainly people who are excited about payment parity, but that might not be the majority of our audience at the moment. But I think that is extremely exciting for a lot of care providers in the space, and also health systems and payers. So can you maybe speak a bit to their perspective as well? What do health systems and payers really benefit from?
So with respect to the two things that you just mentioned, specialists, and then also some of the payment rules, I think one thing that CMS did for the public health emergency, which will continue, and I think they've put out a rule to allow some of it to continue, is really to add new telehealth codes. So to really broaden the list of services that are eligible for reimbursement if offered via telehealth. I think that has been very instrumental in sort of, broadening that list of services, broadening the specialists and reimbursement for specialists. So that, again, was done because of the PHE, but they used their own existing authority that's not necessarily tied to the pandemic. And so we've seen them take action. I think they've proposed, of the 130 codes that they added for the public health emergency, around 80 they've proposed to make, eligible for reimbursement if offered via telehealth on a permanent basis. With respect to payment parity, again, and speaking just because I come from the government world, but speaking about Medicare, CMS announced fairly early on that they were going to pay at parity for telehealth visits, the same that they would pay for an in-person visit. Again, they used their existing authority to do that. So that is something that could continue if they chose to continue that. And then certainly, as has been mentioned, we've seen private payers sort of follow suit depending on their populations and the needs of their clinicians.
Yeah, I would just add, I think, you touched on it as well. I think the geographical restrictions being waived, I think, was a huge change. It enabled providers effectively to, basically give and produce telehealth in urban areas, rural areas, the patient's home for all types of care. So whether it's, seniors in the home, skilled nursing facilities, long-term care sites, hospice. You can do coronavirus screenings from the comfort of people's homes to minimize the risk of transmission. I mean, this was a major change. I also think that the loosened restrictions on the use of telephone to deliver care were actually quite positive as well, mainly because of the fact that, our product in particular complements the phone call quite well. We can do a very great, asynchronous type visit, which basically encaps, all of the different types of data points a provider would need. And then it can be followed up with a phone call to actually discuss the diagnosis. So to have the reimbursement capabilities around that are quite powerful. And I think the last piece, kind of touching, going back up to the geographical restrictions, I think, even the licensure requirement in some state lines being waived, right? So I know it didn't necessarily happen at the federal level, but it did happen across some states, and that allowed some systems to step in and actually produce better care for markets that wouldn't necessarily have the access that they now do by simply having those waived, geographical restrictions. So I think that's also a key piece to add on to some of the comments you just made.
Yes, I think medical licensure has been really a major issue for a lot of players in the telehealth space, particularly hospitals who had maybe experienced a lot of impact from COVID-19 and were looking for assistance from other states in particular. So I'd like to maybe pivot the conversation a bit and look at what we expect to see kind of coming down the pipe. We've seen some signs from CMS that they are indeed looking at making a number of these changes permanent. As Kristen mentioned, something like 80 of the expanded services they're considering just keeping up reimbursements. And I don't believe we've heard the verdict on waiving the originating site requirements long term. But hopefully that will continue. But there are just really a lot of uncertainties right now in light of regulations and in light of reimbursements. With this uncertain landscape for 2021 and beyond, really what should stakeholders be doing? What should care providers and health systems and hospitals and payers, what should they be doing to make sure that both their interests are protected and that they can continue to provide care to their patient populations?
Yeah, so from just a government perspective, I think we, as you mentioned, we have seen signs from CMS that they will use their authority, to the extent that they have it, to make some things permanent. The challenge is that they don't have authority over those geographic site restrictions. Congress actually has to act. So I would say, in addition to all the operational things that health systems and others need to be doing to make sure that they can continue to sort of build the infrastructure needed to offer these services on the long term. I would say, and again, because I come from the government world, I would say that advocacy is very important. If your health system wants these services to continue, you need to let your members of Congress know, because they need to pass a bill to make sure that it can be offered outside of rural areas and to patients who are in their home or their work or other non-facility based sites of care. I think that Congress, I would say Congress is aware that this is something that there is significant stakeholder interest in doing, but they really do need to hear from everybody, especially on those points. So that would be my, in addition to all the operational things that need to happen to make it, a long-term part of the care delivery system.
Yeah, I completely agree. I think the advocacy work is absolutely critical. I think folks have to really look at this at a local level, at a state level. I think, naturally, I think, people have had a taste of telemedicine. They're seeing the power of it. It's amazing. The VA has been doing it for many, many years. I think at one point, up until last year, I think 95% of telemedicine visits were actually happening through the VA. And so, the power of it definitely exists. I think now consumers, and again, patients are consumers, so we have to make sure, we don't delineate between those two. I mean, they are consumers. They force the change across many other industries. I think they're going to, force the change in this particular industry as well. And people can see, you don't necessarily need to go to a physical location to seek top-notch care. You can have it at the comfort of your home. So, technologies that are paving their path forward into the home are only going to make this easier. There's diagnostic testing companies now that are, advancing the capability to do a strep test, a urine test, a COVID test from home. So I think with all of these natural advancements, it's key. I also think that an earlier point was made around building telemedicine infrastructure for the systems out there who are listening. I certainly think if you haven't made the investments, you need to. If you've started to, that's fantastic. It's definitely a path, that you need to go down. It's something you need to do. I think, from my experience, I mean, there are two types of groups that I've worked with. Ones that, offer telemedicine to check the box, and the ones that who are serious about it, who really want to wrap it around the system. And I have systems I work with, they offer telemedicine now across, 25, 26 specialty lines. So can you do it? Yes. You have to be committed to an organization. You have to have the FTEs. But I do think in parallel to the build out of the infrastructure, you do need to really emphasize to your state, local leaders, and let that trickle up to the very top, because this is certainly the wave that we need to ride to make some of these changes more permanent.
And Kristen, one thing I would say, you mentioned earlier the HIPAA waivers that allowed clinicians and systems to use non-HIPAA compliant technologies. So they, OCR, the Office of Civil Rights, who manages HIPAA, used their enforcement discretion. So they didn't actually change the rules. They just said, if you use a non-HIPAA compliant platform, we won't, levy any penalties or bring an enforcement action against you. If you are a clinician or a health system that relied on those continues to rely on those non-HIPAA compliant platforms, you probably want to consider, to the extent that telehealth is a part of your long-term strategy, adopting a HIPAA compliant platform, because the enforcement discretion we don't expect will be indefinite. So that is something, if you're looking at things that may continue or things that may not continue, that is something that is likely to not continue, largely because, the agency doesn't have the ability to allow people to use non-HIPAA compliant platforms at a long term, and there is still some risk even with the exercise of enforcement discretion. So I'd say that's another thing, of all the things that may continue or may not continue, that is one that we feel may not continue.
Okay. So what would you say is a solid new opportunity that has emerged for players in the space that's maybe the players should be just capitalizing on?
I can start with this one if you'd like. I think just, the build out of the telemedicine infrastructure for systems is going to be a key opportunity to highlight. I think, the complex care that you can start to do from people's homes, I think there's the sky is the limit. There are companies cracking literally the concept of basically bringing the hospital to the home. So home hospitalization. There are a number of programs I work with directly today that have basically built out, COVID hospitalization programs, home hospitalization programs, where, they can discharge patients earlier on in the process. They can, basically manage these families who prefer to actually be at home and have that convenience and comfort. So I think, really the opportunity here is to tap into, some of the early signs of what telemedicine can do in bringing this care to the home, but really start to think about as well. I mean, for patients who are in the hospital, could they be discharged earlier on in the process? Do they even need to be admitted? Could it potentially be monitored and triage from people's homes? So I think this is a large trend that will continue on and increase into the future, and certainly could be something that systems could invest into in terms of that infrastructure.
Yeah, and I agree with that. So just finding the, rather than, I think what we've seen during the pandemic is just sort of substituting in-person, what would have otherwise been in-person care with the telehealth visit. And so I think The next phase is to figure out and more deliberately integrate telehealth with in-person care and other types of maybe digital tools. So, remote patient monitoring, you can imagine like a model, for example, that includes some in-person care, some video or other telehealth services, plus remote monitoring, plus the use of AI or behavioral nudges or other technology tools that offer us an insight about the patient. But really, the challenge is going to be figuring out how to wrap it all together and when one modality is appropriate versus another modality and how it all fits together.
And I'll just add too, I mean, this is the perfect time. There's a lot of funding out there as well. I mean, we have the FCC that put forth a $200 million grant over the past few months and deployed that money to systems who really needed assistance in building out that infrastructure. And in some places, right, you look at Alabama, their issue is not even necessarily having telemedicine equipment. It's actually having broadband Wi-Fi capabilities in certain parts of the state. So I think tapping into the USDA, the FCC, those dollars will hopefully continue to expand further into this year and next. So I think if you're a provider, certainly look at channels to work through those dollars to help your budgets in acquiring that type of tech. But if you're an entrepreneur or if you're a tech nerd and you see this as an opportunity too. I mean, there's a lot of opportunity in bringing this type of care into the home. So I think a lot of new technologies to come in the next 12 months.
That's certainly an exciting time. So we actually have quite a few questions from the audience that we're going to try to tackle. We might run out of time to answer all of them, but we will try to get as many as we can. So yes, David, the first question is to you. Can you talk maybe a bit about organizations that are doing well with remote patient monitoring billing using the TitleCare solution and why you think they are successful?
Yeah, so we as a company, know our core competency. We are a best-in-class examination platform, and so what we've done is, in some places, we are being used as an end-to-end solution, but in more places than not, we're usually being used as an integrated solution into the EMR, for example. So Epic happens to be one of the electronic medical record systems that we're very integrated into, which basically allows you to use both our asynchronous and synchronous means directly tying into the RPM modules that Epic offers. We're also working pretty closely now with a number of RPM type companies. So we're basically tapping in and working with groups who are specialized in this and maximizing what we consider our best-in-class examination platform within those different types of solutions. I would say the biggest change that we're seeing in terms of the RPM space is that for so long, RPM has been really just focused on monitoring for the sickest of the sick. And I think nowadays, there's this new concept, which is basically, being born kind of because of COVID, and it's telavigilance, right? It's actually helping folks to be much more health conscious and be much more proactive. And so there are devices out there that help you do that. There are, the Apple Watch, for example. So I think those elements are going to only progress, not only for the sickest of the sick, but also for those who are healthy and just are much more health conscious.
Okay, very exciting. Thank you. And then the next question is aimed at Kristen. So outside of the PFS that will come this year, how serious is the elimination of the originating site restrictions this year and next? What's the buzz and realistically before or after Election Day?
That's the question. That's the million-dollar question. So there is very serious buzz, I would say, about extending and making permanent the restrictions. Some of it hinges on what happens in Congress. So they're in recess now. They will be back in September. They have government funding to deal with. They have not been able to pass an additional COVID package, which would be a natural place for these telehealth, provisions that would make some of the flexibilities permanent. So it's a little bit of a wait and see game because we don't know which, how many bills will be moving through Congress. I would say, what we've seen so far from CMS is to say that they will extend the flexibilities through the year in which the public health emergency ends. So right now it's slated to end in October, which would mean that the flexibilities would continue through the end of 2020. If the public health emergency, it can be renewed for 90 days. So if it was renewed in October for 90 days, it might continue into 2021. But I mean, it will be, it's a little bit of a wait, like I said, a little bit of a wait and see game. I think we will be able to see, if not action from CMS, action from Congress to extend the flexibilities at least through 2021. But again, there's, Congress needs to hear from people. So don't take that as, a sign that we don't need, everyone to advocate. We really do need to be ready, but they are taking it seriously. So we're hopeful to see something, even if it's just a longer extension beyond the PHE.
Yes, I mean, we're all very hopeful that we'll see some good permanent changes as a result of all of this. So another audience question, I think this will be the last one we have time for. Can you talk maybe a bit about reimbursement model changes? For example, changes to value-based care. Are you seeing more discussions on the Hill that the shift will happen sooner?
So there are definitely discussions about value-based care, particularly with respect to connected care. A lot of discussion about how, at-risk models are an appropriate place to really sort of allow unfettered use of telehealth and other services, because, if you're at risk for your patient population, there are not quite the same concerns around utilization as there might be in a fee-for-service population. So I don't know. I think that the conversation right now is really more large scale and broader, allowing broader use of telehealth. But there certainly is a commitment to value-based care and using these technologies. We've seen in a number of the CMS Innovation Center models have waivers that allow expanded use of telehealth already. So on the Hill, I think that they, as far as whether we'll have a faster movement to value-based care, I certainly hope so. I think that the pandemic has really illustrated the challenges of the fee-for-service model. With such steep declines in patient volumes almost overnight, there were practices and physicians that had 80, 60, 70, 80% reductions in their patient volumes. That's very hard to sustain. You're a little bit insulated from that in a value-based model. Although you feel challenged, financial challenges too. In a value-based model, you are a little insulated. And, certainly if you're in a shared savings model or something and you have a check coming at the end of the year, that's money that you can count on. So I think that there is certainly an understanding that the fee-for-service model was really, its challenges were sort of laid bare by the pandemic.
And yes, thank you, Kristen. And also thank you, David, for joining us today. I'm afraid that's all that we have time for. But yes, this was an excellent discussion, and very much appreciate having you here with us today.
Thank you so much.
We're going to our next panel, and we'll reconvene in just a minute. Sorry. Oh, are they still on? Welcome back, everyone, and welcome to our final panel of the day, looking at the trends and challenges involved with virtual care. So one of the trends we've seen really emerge this year is that consumers and others are very interested in a variety of models for virtual care. They're interested in remote visit platforms that connect them with local physicians, with hospital systems, and with doctors nationwide. They're also interested in sharing data from devices that they have inside their homes and having that data being used to inform their care. An increasing number of providers and health systems are also interested in rolling out virtual solutions internally, using virtual tools to provide inpatient care, allow for remote collaboration among healthcare workers, automate scheduling processes, and improve internal efficiencies and communication with patients. There have been quite a few changes this year, all in all, with more coming down the pipe. I have a few experts with me here today to discuss some of these changes. Paul Bryant with Athena Health, Michael Farrell with MD Live, and Amar Kendale with Livongo. They're going to take the next few minutes to introduce themselves and their companies. First is Paul with Athena Health.
Thanks, Kristen. I'm Paul Bryant. I'm the Chief Product Officer for Athena Health, and I'm celebrating my almost exact 1 year workversary here. I've been a healthcare IT lifer, spent the early mid 90s at a payer-focused company where did a lot of work around case and disease management, which is kind of what we call population health now, and sold that company into HBOC and McKesson. So that was a very interesting experience for those of you who know that health. And then joined a small company called Patient Keeper and built that into a physician-centric computing platform for physicians in the hospital. We sold to HCA, and I was an executive at HCA for the last 5 years, and then joined Athena Health. So one of the cool things that I got to do, thanks to COVID, was to help Athena build a full-fledged telehealth platform, which you can see the ad for on the screen. We've got over 10 telehealth partners, plus now our own native telehealth solution as part of our ecosystem. So it's great to be here. Looking forward to talking more about virtual health.
Thank you. And then Michael, I think you're next up. Can you maybe tell us a little bit about yourself and about your company?
Absolutely. Thanks so much for allowing me the time to be here today, and very excited to be along with the fellow panelists. By way of background, Michael Farrell, I'm the Chief Revenue Officer of MD Live. I'm coming up here on really 3 years at MD Live, but I'm a lifelonger HCIT guy as well. Been in the industry for almost really about the last 18 to 20 years. I spent around 13 years at Cerner Corporation in a variety of leadership and executive positions before I came to MD Live, and have been focusing on virtual care since around 2018. MD Live is a leading virtual care company in the industry, organically grown, been around the industry for about 11 years. We have about 2,300 board certified doctors, all MDs that take care of our members and patients across the United States. Our providers have backgrounds in primary care, internal med, family practice, pediatrics, emergency medicine. We do have about 600 behavioral health clinicians, as well as about 200 dermatology doctors around the country. So single platform, but happy to be in the virtual care space, and very look forward to the conversation today. So thanks so much for allowing us to be here.
Oh, thank you, Michael. And now Amar Kendale with Livongo. Amar, can you tell us a little bit about yourself and about Livongo?
I'm happy to, yes. So my name is Amar Kendale, and I'm the Chief Product Officer at Livongo. I joined Livongo just over 6 years ago, which is when we started the company. And what Livongo has been focused on is empowering people with chronic conditions to live better and healthier lives. So we took the idea that healthcare is a one-to-one experience and really evolved that into a tech-enabled experience designed for the end user to make their lives easier and better. So we do this through something we call our applied health signals capabilities. It's a combination of remote monitoring, telehealth, as well as data science in order to create signals that we can then use either to offer to our members, which is what we call our users, in order to change their behaviors, or to other members of the ecosystem. That includes providers and other care team members. So our platform really sits on these three pillars: remote capture of data, which we do through a number of devices, including many of our own that you see on this slide, our own blood glucose monitor, our own blood pressure monitor, typically with a cellular connection in order to produce very high data frequency and low latency. We then take this data and put it through our data science engine in order to generate those insights, which we can offer back to people. And finally, sometimes you just need to talk to a person. And so we have our own team of certified diabetes educators and other health coaches who support our members in those times that they need more than the digital offering alone can offer. And at this point, we've been able to grow our services to expand beyond our beginning in diabetes to include now hypertension, weight management, prediabetes, high cholesterol, and even behavioral health, knowing that these conditions all influence the outcomes of a group of people in many times overlapping ways. Something we call our whole person approach, bringing all these conditions together into one experience that is fundamentally technology enabled in order to give it scale. The most recent news about Livongo is that we just recently announced a proposed merger with Telehealth to create a global company that has the potential to lead in consumer-centered virtual care. It's something we're very excited about.
Awesome. Thank you, Amar. So before we head into our discussion, I'd like to ask the audience another quick question. So audience members, which change in the healthcare landscape do you think has the biggest impact on increasing virtual care adoption? So I think a few of you were able to get some questions in, your responses in a little bit ahead of time. But if you hadn't, then please take the time to go over to the polling tab and then select your response. And we can maybe speak a little bit about that topic. So as that's going on, let us turn to our panel discussion. So since we're in a virtual kind of setting today, 3 different panelists, one of me, maybe we could do something a little bit different. So let's go for the first question in alphabetical order and see really how that works out. So starting things off with Paul, then Michael, then Amar. So same order. But using one word, how would you really characterize the virtual and remote care markets in 2020, and also why?
I would say transformational. And virtual care and remote care wasn't invented after COVID. It's been around for quite some time. Back in the 90s, we were working with Bluetooth or I guess hardwired connected scales for CHF. But now everyone's getting to experience it. And I think that's going to create a whole set of innovations that we can only hope for and guess at as we sit here today.
All right. Transformational is a good word. I like that, Paul. I would say unprecedented. It just, being in the virtual care telemedicine industry for the past 3 or 4 years, we're constantly, continuing to work with our health plans and our health systems around the country to buy into adoption and to get consumers to buy into adoption and to engage in virtual care. And overnight, the industry shifted to where no one wanted to go in anymore to brick and mortar doctors' offices. They were worrying about contagion. They were worrying about, if they were going to get sick or get COVID, and virtual care exploded overnight. So unprecedented is the word I would leverage. And I truly think it's forever changed the way healthcare will be delivered now. There's a virtual first mindset and a remote mindset from a diagnostic perspective. And I think that's changed forever now.
Yeah, so I would, my word is catalyzed. And I'd say that what's happening in this moment, as both Paul and Michael alluded to, is that there have been these activities going on for decades when it comes to the elements of the system here. But what's been missing is breaking through these walls when it really fundamentally comes down to behavior, whether that's behavior from patients or members to adopt these services that feel unfamiliar or difficult to access perhaps. It means changes in behavior from providers who haven't been motivated with favorable reimbursement in the way that they are now. And of course, motivation from legislators to make that kind of reimbursement feasible for technology and really upset the incumbents and potentially threaten what had come to become a very stable and profitable industry. So I think that what we're seeing is this enormous acceleration that's driven by changes in behavior that are in turn driven by structural factors, COVID-19 being one of them, but in quick succession, changes in reimbursement and then changes in consumer behavior. And I think it's that last one that matters the most, because it's going to be impossible to put the genie back in the bottle.
Yes, I definitely agree. And tuning into our Ask the Audience poll, I see that a lot of our audience members are thinking that something that was really, really impactful was just providers really needing to adopt telehealth in order to operate in a COVID-19 environment. But I'm also seeing a fair amount of people saying that high consumer awareness and familiarity has really had the biggest impact on increasing virtual care adoption, and also that increased reimbursement piece as well. So there's just been quite a few very impactful changes this year. And then as three companies really operating in this virtual care space, are there any metrics that you can share with the audience about some of the virtual care usage trends on your platforms? Let's maybe start with Amara this time, then Michael, then Paul, kind of the reverse order.
Sure. So one of the things we've observed is that it's very difficult to provide virtual care for people with chronic conditions in the absence of data. And that information that clinicians need in order to make those clinical judgments to care for their patients now suddenly needs to come from the real world. It can't come from what happens in the course of the office visit or in the course of the emergency room visit. And so it has pushed that frontier of where the data needs to be generated and from where it needs to be transmitted out towards our users. So the trends we've watched are significantly increased utilization of Livongo services. For people in our diabetes program, in our hypertension program, in our weight management prediabetes program, we're seeing roughly a 10% increase that's associated with this COVID phenomenon in both device and mobile usage. And that really illustrates the fact that people need to see their data go somewhere where it can be useful, whether that's sharing with their physician or whether that's simply bringing to a place where they can get insight and support in order to make sense of what their numbers mean. Another really interesting thing we've noted is, unfortunately, we're seeing an enormous increase in the stress levels of our members. And they tell us every time they check their blood sugar, they tag whether they're feeling stressed or not. And what we've seen is that stress tag usage has nearly doubled in this period of time. So we think it's the beginning. I mean, we're in the middle, actually, of a behavioral health wave, that's going to crash imminently. And so it's something we need to be ready for.
Great point. And to segue off of the comment around stress, I mean, MD Live has seen nearly a 510% increase in our behavioral health visit and consultation and overall, book of business since this time last year. I mean, just with the need and what Amar said around the uncertainty in the environment today, COVID, and unemployment. People are losing their jobs. So, I mean, behavioral health has been a vital need for accessing a therapist or a psychologist or a psychiatrist virtually for MD Live, and it's been one of those feel good stories that you really feel great about being able to offer that vital need to connect a member or a consumer, a patient in with the behavioral health specialist when and where needed. To get Kristen just a few other stats, I mean, so MD Live medical visits, so our urgent care business is up about 83% on the number of urgent care volume that we saw this time last year to where we are right now. NPS scores, that's something that we constantly monitor at MD Live. We want to make sure we're ensure we're satisfying the members. It's also in the height of COVID. It did dip in March from where it was last year, but it's continued a trend rise and an increase over the last 3 or 4 months. And overall, I would say volume has picked up. That as you would know, where MD Live did about 1 million visits last year during the whole year, and we did 1 million visits within 7 months of this year. So just an overall increase in the volume from a virtual care perspective. But I would say the fantastic story is around the behavioral health and really helping people in need right now across this environment. Paul?
On the other side, we kind of sit in a unique place. We support over 75,000 providers across the Athena network with full clinical ambulatory EMR. So we got to see the real shockwave of COVID on these practices. And if you look across our network, within 4 weeks, the percentage of visits being done virtually went from less than 1% to over 34% just in the course of 4 weeks, and peaked in mid-April. And we have a variety of partners. Most of the telehealth vendors out there are available on our platform, and obviously a lot of this volume went to them. There was also a tremendous amount of kludging going on with the relaxation of the HIPAA requirements, a lot of FaceTime visits, a lot of just straight up telephone visits. Pretty interesting array of stuff, which is what motivated us to introduce our telehealth offering as well for those that didn't want to partner with one of our partners. The interesting thing, though, to look at from a statistics perspective is that the percentage of telehealth visits peaked in mid-April and has been slowly declining since then, and is now around 10 or 11% of the overall visits on the Athena network, which is still more than a 10x improvement. So if I told you, hey, look, telehealth is up 10x on the Athena network, you go, wow, that's awesome. Somehow it feels a little weird to have seen it come down. But I think what's happening is that people are kind of figuring out the place for it, and also just did everything they could telephonically. And then at some point, you do need to come in and see a physician for some things. So it's been a really interesting thing to watch. And I still feel like we're still in very much early innings in this situation.
Interesting seeing things evolve as we move more towards the fall and winter months and into the cold and flu season, and also as schools continue to reopen. So maybe let's pivot a little bit and look at really specifically the hospital health system and private practice space. So many of the players in these areas are really adopting virtual care solutions, and they're training their physicians in terms of providing such care. So it's a lot of logistical changes, a lot of operational changes. Really, from your perspectives, what would you say are the biggest pain points that these providers are maybe running into trying to roll out these solutions at scale? And really also, how are companies in this space working to resolve these pain points? Let's maybe go again the reverse order. So start with Paul, then Michael, then back to Amar.
Sure. No, I mean, in many ways, physician practices had to almost reinvent themselves in the course of weeks with no real preparation or advanced warning to be able to see, in some cases, 100% virtual, in some cases, a mix of in-person and virtual. And just all kinds of new pain points have occurred. Everything from, how do you check in people in their car to how do you get connectivity to patients? I think, at least early on in this, the biggest challenge was patients bring whatever technology they had. In some cases, it's almost like going back to a museum piece. And, physicians and their staff are great for delivering medical care, but really aren't tech support desks. So just helping clinicians or helping patients engage in the technology has been a big barrier. Getting the practice workflows right when you've got a mix of patients that are physical in person and virtual. Is it every other patient? Do you try to do all the telephonic ones with one provider versus inpatient? How do you adopt the new cleaning protocols and the PPE protocols within the practice for the patients that come in? It's been an amazingly challenging time, and the thing that I've been so impressed with is just how resilient and creative physicians and their practices across the country have been.
I agree, Paul. We work with quite a few hospitals, health systems, academic medical centers, for-profits, IDNs, community-based hospitals. And just what Paul said, overnight, they were thrust into having to operate and operationalize virtual care in an environment where maybe a technology wasn't able to fulfill that need. So I think some of the biggest challenges we saw was how to get providers up to speed as quickly as possible, how to operationalize what they had. Maybe they were even using Zoom or VidYO or Teams, but how to operationalize that in their practice and in their infrastructure was a challenge because they had to meet this growing demand of being able to service patients and do it virtually. So they were picking up the phone and using the telephone. They were using third-party video links to send in and out. I think some of the challenges are just the same in the overall provider market ecosystem. It's around the integration of a lot of these different various technologies and capabilities and morphing that into their electronic health record so they continue to have the continuity of care that they need for the patients that they're taking care of. I also think ease of use and the simplistic, frictionless consumer experience is, highly important. And I think it wasn't just on the providers, it was on the patients during this time as well, to be able to connect and see their doctors virtually, that I think a lot of, there was challenges overall, but companies like us, and I know Livongo and Athena are continuing to work on our, our products and our integrations and our technologies to make it more consumer and provider, a frictionless experience overall. But those would be my comments.
I would add that, if you're a physician, if you're a primary care physician, for example, and caring for a person with a chronic condition, you're really at a pretty big disadvantage when you're trying to do everything that you would normally do in the office visit remotely. And some of those challenges include the data that you've come to rely on, the clinical information that you use to make decisions about treatment, whether that's lab values, whether that's medication data. Some of that makes its way to the electronic health record. But if you can't collect it in the first place, if you can't send a person to the lab that's on site, how are you going to deliver that care? So what we're finding is that as we start to identify what those clinical workflows are, the common ones in particular, for caring for people with very prevalent conditions, high blood pressure being a great example, how do we make sure that those clinicians have the data that they need in order to make those decisions? That's really, I think, what's brought into focus at this moment, how important remote monitoring is. And instead of being a nice to have, it's suddenly become a must have. So the work we've done over the years to streamline the collection of that data, to bring it to the cloud using very reliable connections like cellular, to analyze and process the data and produce something that a clinician can act on, is something that we're finding a lot of really great receptivity to. I think it's one of these phenomena where if it wasn't forced by the circumstances, it might have been years before we were seeing the kind of adoption that we are, but we are now really experiencing pull in a way that we haven't before. And I think that's going to continue and accelerate.
Yeah, certainly a lot of stakeholders really all over the space, just getting their feet wet for the first time, figuring out what they want and need, and also just figuring out how virtual care can work for them and make their lives easier, open up new avenues that they hadn't considered it before. So I guess building a little bit more on this topic, 2020 has really just been a major learning experience for really players all over the healthcare ecosystem. So speaking again to that big trend of providers really needing more data to drive care decisions and create care experiences, can maybe each of you talk a little bit more about this trend and how it's impacting your businesses, and also maybe look a little bit about how the needs of stakeholders and consumers overall have really changed as a result of COVID-19. And then let's do that reverse order since it's working well for us. So Amar, Michael, and then
Sure.
Paul.
Yeah. So if just to make sure I understand the question, if you're asking about how have these trends for more data impacted our business, and then what are we seeing in terms of consumer expectations and behavior?
Mm-hmm.
Okay.
Yes.
So yeah, I think when it comes to the changes in consumer behavior, it's another one where we're just starting to get a really good understanding of how profound health behaviors have been affected. Some of the things we see, I did speak about increased usage of our devices and apps, and that's good news. That means that people are proactively managing their health in a way that they hadn't been before, at greater rates than they had prior. There are some negative trends that are troubling though. And a great example is that what we see in our data is a significant reduction in activity levels. And this is a really dangerous harbinger. In part, people are home and getting out less than they used to for a period of time when we were locked down and it restricted a lot of mobility. And there are certainly going to be long-term impacts from the fact that people are less active than they had been prior. So a lot of our work in response to that kind of trend is to figure out how do we educate a person on the kind of exercise they can do in their own home. If they can't go to the gym anymore, how could they do strength training using their own body weight resistance as an example? So it's forced us to shift some of our own content and programming in order to accommodate these strange phenomena that we're seeing. And in many cases, we have to look at our own data to try to investigate and uncover some of these phenomena. I already spoke a bit about stress. It's really the entire continuum of behavioral health needs that's starting to emerge. Social isolation, of course, is a huge phenomenon that people are experiencing, particularly younger people, that needs to be addressed, that we need to be proactive about addressing, and can have very significant impacts on health at both the personal and national level. So what we're starting to do a lot more of is figure out how do we bring more of those, what I might call adjacent services or auxiliary services. For a person with diabetes or hypertension, you may not necessarily think about isolation as being a factor that can really influence their management of their condition, but it turns out it is. And so we need to think with that much broader lens.
Yeah, great points, Mark. Fantastic points. And like Livongo, MD Live is highly focused on data and looking at data and trends to continue to fulfill our mission and vision within the healthcare ecosystem. For us, what we've learned, we've done proprietary research studies since COVID hit, and looking at really the trend outwards around virtual care and the landscape, and it's really focused around urgency, around getting to a doctor quickly for the condition that you seek. It's around the contagion-free environment, so being able to offer access in a safe and comfortable environment to be able to see your provider is at the top of the list. And the third one's really around the speed to treatment and being able to see a provider within 10 or 15 minutes. So we're continuing to update our messaging and our research and our engagement with our clients to really focus on the factors of what we've uncovered throughout our research, and moving really towards the virtual primary care ecosystem, to be able to care for the holistic patient and not just select conditions is of primary importance. And what we found in our research, to be able to offer multiple services and really take care of the whole patient virtually.
Yeah, it's been an amazing time, and put a ton of pressure on data. And frankly, I think as a country, we've learned some of the dangers of fragmented electronic medical records. We did a whole bunch of work against the data that we have. As a single instance cloud-based vendor, we were actually able to run queries across our entire ecosystem to see if we could learn anything about COVID itself and the response to COVID, and looked at various drug combinations and see if there are people on drugs that either had a better or worse outcome. Looked for high-risk vulnerable populations in terms of where they are to help support some of the public health initiatives around the country. It was really fascinating to see what the power of having at least a sampling of the data across the country could do. The other thing to look at, in the shock that stunned me, we did a lot of looking at the just healthcare volumes by procedure type across our ecosystem. And one of the things that declined the slowest but has recovered the slowest is ED visits. And at some levels, everyone's always talked about avoiding ED visits, and a lot of people go to the ER where they do not need to. And I think we might be seeing that. It's been the slowest to recover, and it may be that between virtual care and just finding the appropriate location of care, that people are finally using the ED for what it is supposed to be used for. So that might be a good silver lining in all of this. And then lastly, just to kind of build on Amar's point about kind of the whole patient, so much of the U.S. healthcare system is based around the encounter, right? No healthcare occurs until the patient checks in, and then healthcare is done when the patient checks out. And I think just this move to virtual and the COVID crisis and the need for surveillance has really started to have opened people's eyes to that we got to be thinking about the whole patient all the time. What can we get from remote patient monitoring? What can we get from different places in the healthcare ecosystem where medical records might live? And how do we really treat the whole patient the whole time?
Okay. So on our last panel, we talked a bit about how some of the changes in telehealth reimbursement that we've seen over the past 8 months, a year, have really impacted business models and how business models have changed to take advantage of these sorts of reimbursements. What have you kind of really seen as being a major opportunity in this market that you might have capitalized on, or maybe a new area of growth that has opened up for you? And then anyone can jump in on this one.
This is Michael. I would just say, overall with, CMS reimbursing at parity, many think that this will become the norm and the permanent. I don't think it's anything necessarily that we've changed from a business model perspective. We've always been in the Medicaid managed care business, the Medicare Advantage, but it does open up a lot of opportunity and possibility for the hospitals and health systems that we work with as well in their business models to where they continued, the past 5 or 10 years to build out brick and mortar buildings and offices and new hospitals. And I think their mindset will continue to shift to a more virtual environment, especially as hopefully reimbursement stays where it is today. And they'll be able to capitalize on individuals being taken care of in their own home and virtually, and not having to expend capital on necessary infrastructure to take that into account. So overall, I think a lot's changing, especially for the provider market. But we'll see as the reimbursement mechanism come into play, and we'll see what the following years brings us.
Yeah, I think in a similar vein, I mean, our business model at Athena is the same as it was before. We support ambulatory physician practices. But what we've witnessed, I guess, in the short term is without that reimbursement change, many practices wouldn't exist. It wasn't so much changing the business model, it was saving their business. I think, though, as you look at the implications of that long term, we start to see opportunities for non-traditional entrants. Because healthcare used to be a local game, right? There was no really kind of global competition or even regional competition to many respects. But with virtual care now, the competition and the opportunities for people to get healthcare from people that are not in their geography is opened up quite a lot. And we see a lot of the players on our ecosystem that are doing some pretty creative things. You probably saw the announcement with VillageMD and Walgreens recently. And they're really thinking about a national healthcare strategy, which is not something that we've seen lots of in the U.S.
Mm-hmm.
Yeah, I'd add that all of this is within a much broader context of value-based care, and fundamentally that's the trend that we've been focused on. Suddenly what's happened though is consumers are forced to make more decisions about how they consume care than they had in the past, and they have more choice. And I think that's really what's going to drive a lot of what sticks in the models that we see going forward. People are, in many cases, having a better experience when they're starting with virtual first and then moving into the office or health system environment when needed. I think that's going to be a harbinger for a long-term evolution and change. It is going to produce better value for consumers and for the system. And then we're going to add more to that. I think as we're able to virtualize more, direct people, to brick and mortar when it's necessary, but let them stay home when it's not. I think, we're going to see that as an expectation from consumers, and we're seeing already a growing awareness from providers that that's a better experience for them as well, and potentially a way to generate great value, which in the long run is going to matter for health systems just as much as it does for consumers.
Okay, so we certainly can expect to see really just this increased reimbursement continue on to the future, increased demand by consumers, by care providers and others, and also the increasing evolution of competition in this space and entrance of new non-traditional players as well. So we actually have quite a few questions from the audience right now that we're going to jump into for the next 8 minutes or so. So first question is aimed at Michael and Paul. So are you seeing more virtual provider networks being formed, or are you seeing virtual health plans being created that really help to supplement the brick and mortar in the region?
This is Michael. No, not really. I mean, we're not seeing a ton of new virtual provider networks out there being formed as a network per se. What we are seeing is the more and more health systems and provider clinics out there offering virtual care just for their own established patients if they need to, but it's not necessarily like a true virtual network. I mean, from MD Live's standpoint, we've continued to grow our virtual network. Over this year, we've added 500 or 600 more providers just to ensure we keep wait times down under 10 minutes. And our plans are working with us to continue to ensure that we grow the network and have the right infrastructure in place to be able to service all of their members. But not really seeing the growth in virtual networks overall. No.
Yeah, I think similarly on the Athena network, I think it may be just a little early for that. I mean, the health system just underwent this incredible shock. People are trying to just recover a bit. But certainly we are seeing many of our customers expand their telehealth capabilities and their geographic reach. And I would expect that we're going to see some very new and hopefully exciting business models over the next year or two as we kind of get back to whatever the new normal is, and people are able to innovate on a little bit more terra firma than where we've been for the past 7 months.
Yeah, I'd say we're seeing movement here, but I think it's the case that health plans and other payers are forced to scramble to try to come up with a solution that really covers the bases, and it's because nothing is truly comprehensive enough to address the entire breadth of needs that we're now uncovering. And so I've seen some work as an example, bringing together asynchronous chat-based primary care telemedicine with synchronous video-based from another vendor, different types of networks addressing primary care versus specialty care. And right now, I think the fact is those are often coming from a number of different vendors pulled together into some kind of network structure. And so I think it is a bit of a primordial soup. I think we'll start to see things shake out. We'll see the models that work and the ones that don't. And I think the big driver here is going to be for clarity in consumer workflows, what's going to be easy to participate in. You don't want to be bounced around between multiple services. And what's going to create continuity of care, so that you actually have the ability to care for a person's whole health, and so that fragmentation doesn't happen that I think we've all been nervous about, and continue to need to be mindful of.
Okay, then Amar, this next question is aimed at you. Can you talk about what works from a consumer's perspective that supports behavioral changes? For example, what is it that the patient is sticking to that Livongo is providing in its platform and solution?
Sure. Yeah, this is something that's been an area we've developed a lot of learnings over these past several years. And what we've found, one thing we found to be very effective, I'll just give one example, is something we call habit stacking. And as we began building services for people with diabetes, what we learned was for many people, checking blood sugar was already part of their routine, but it wasn't very valuable. And so they were told by their physician, I want to see you check your blood sugar a couple times a week, maybe once a day, and write it down in this paper logbook and bring it to me in 6 months so that when I see you, I can make adjustments to your medications. So what we found was the habit was there, but the value wasn't there. And what we could do was instead take that existing habit and ladder up the value by creating more feedback loops, by creating more actions that a person could take, recommendations for things they could do, because we knew they were making an investment of their time in this behavior. So given that fact, we were able to take an existing habit and at the same time put it in front of someone a recommendation or a question. Here's your blood sugar. Blood sugars are looking great, but what do you think about trying this, taking a walk after lunch every day and adding this to your routine? So starting with one habit and then using that to build a second habit on top was something that we found to be really effective. We've gone on to explore this area quite a bit with a product feature and platform we call Health Nudges. The concept being that if we can give you just a gentle nudge at this appropriate moment in a very timely fashion that's very personalized, we can make it easy for you to make that health decision. And so that's something that has been a really powerful learning. We've gone on to apply that to the other conditions we work with, hypertension, prediabetes, and even now beginning to do the same thing with behavioral health.
Very cool, very cool. So next question is for Paul. So how does your strategy to offer telehealth impact the Athena Health marketplace, where there's a couple of other vendors also offering telehealth to your users?
Yeah, I mean, Athena's strategy is very much we're an open ecosystem, which means that everybody and anybody who would like to participate in the ecosystem is encouraged and supported to do that. So we're excited by the fact that we've got a whole variety of telehealth providers on the network doing all variety of different things. We also believe that it's now an important and mainstream enough part of healthcare, as we've been kind of discussing, that many of our clients are like, hey, at least a basic telehealth capability should be an essential part of the platform. And so we're responding to customer needs. So I think as with many things in the ecosystem, we'll see a lot of differentiation across the partners and across what Athena offers. And our customers will be able to pick the best solution that works for them.
Mm-hmm. Very good, very good. So it looks like we have a few more questions. This next question is aimed again at Amar. So if data collection is a pillar to better care, how receptive or concerned have consumers been to sharing their health data with providers and, of course, with Livongo?
So, I think it has a lot to do with, in a sense, the explainability of what we intend to do with data. And so something we try very hard to do is make those use cases really clear up front. We don't collect data unless there's a use case in mind. I know there's been ideas in the past in healthcare around, let's collect all the data and put it into a data lake and then fish in the lake and see what we can come up with. That's something that's fine maybe in the consumer world, but it's a very different thing to do that with health data, which is private. It needs to be kept secure. And so to that end, we only collect the data that we need. We have a use case in mind, and we look to prove out the value of that use case. And fundamentally, the way we look to secure the data for our members is to tell them what we intend to do with it and get their permission in order to use the data for those purposes.
Okay, and then we have time for one last question before breaking and going into our community discussions. So I guess this question is aimed at all three of you, and any of you can really speak to it if you'd like. So has anyone studied the issue of the probability of overlooked health conditions by doctors who primarily see patients, specifically by using telehealth? For example, I believe there are certain cases where patients were diagnosed via telehealth medical second opinion, specifically that they might have been missed originally. Has anyone looked at it the opposite way?
Nothing's ringing a bell from my perspective on that research that we've done.
Mm-hmm.
No, but it should be. Someone should take an active look at that. There's an opportunity to close gaps in care. I mean, we work with health systems and providers and health plans to close gaps in care when we're ingesting data from various ecosystems and health records, so our providers can leverage that to help close gaps in care. But I don't have any research to your earlier question, Kristen.
Okay, so it might be an interesting avenue to look at in the future as telehealth adoption continues to increase and patients maybe begin to focus almost exclusively on virtual care as their preferred care modality. So,
great.
But yes, thank you all for joining me for this panel, and I'd also like to thank our great panelists for participating in this this very illuminating discussion. It was wonderful first day of our Connected Health Summit. I would also like to say a thank you to our sponsors for making this event really possible. So Alarm.com, Nortec, Athena Health, Softtech, Beckler, and Sprosty. Thank you all for your sponsorship in this Connected Health Summit, our 7th annual. Up next, we have our networking discussions going on right now. So you can find the links for them on one of our pages. I believe the marketing team should be actually sending out the links in our chat box, so you can just click on them and join the discussion that you're interested in. So you'll have a few extra minutes to get in before they actually kick off the discussion, but it's a great place to stop by and maybe learn some additional facts, or if you have some questions for the analyst team or even some of the other attendees of the conference. It'd be a great way to get those questions answered. So yes, thank you all again for joining us on this first day of the Connected Health Summit. And I certainly hope to see you again on the next few days of this summit as we continue to explore a lot of the issues that have come up this year and a lot of